All right, welcome back. Today we're diving deep into a pathogen that's really earned its reputation as a modern superbug. Salmonella, enterica, serovar, Typhi. You know, this bug has gone from being a textbook case of febrile illness to a truly formidable public health threat.
Okay, so let's get right into it. We're going to unpack how this bacterium, which, by the way, is uniquely adapted to humans, has systematically outmaneuvered pretty much our entire antibiotic arsenal. It's like watching evolution happen in real time, right before our eyes.
And just so you know, all the information we're covering today comes from a comprehensive deep search. We've made the full source notebook available, so if you want to dig into the data and see the sources for yourself, you absolutely can.
So, here's what we've got on deck. We'll start with its basic biology as a human-adapted pathogen, then move into the lab to see how it's identified. After that, we'll cover the really critical part, the rise of resistance. Then we'll look at treatment guidelines, infection control, and we'll wrap up by looking at the next big challenge on the horizon.
All right, Section 1. To really understand the challenge, we first have to understand the foe itself. So what are we dealing with here? Salmonella enterica, serovar Typhi, is a gram-negative, facultatively anaerobic rod. But the single most important thing to remember about it is this: it's strictly adapted to humans. Unlike most of its Salmonella cousins, which are zoonotic, this one uses us, and only us, as its reservoir. And that one fact has massive implications for everything from its control to its evolution.
And this is where it gets really interesting. Because it's a human-only cycle, any antimicrobial resistance we see is driven exclusively by our antibiotic consumption. There's no agricultural runoff to blame here. It also means we have chronic, asymptomatic carriers, people who are walking silent reservoirs, often carrying the bacteria in their gallbladder. And these carriers, they can hop on a plane and transport a highly resistant strain from one continent to another without ever feeling sick. So you can see, control has to be laser-focused on human public health, sanitation, hygiene, and of course, antibiotic stewardship.
Okay, so let's move from the what to the how. How do we actually find this bug in the lab? Let's get into the investigation.
The investigation usually starts with a gram stain, right? And you'll see what you'd expect, gram-negative bacilli. It's a quick first look, but it's totally non-specific. For a definitive diagnosis, you've got to have culture. That's the gold standard. Blood culture is key in the first week, though bone marrow is actually the most sensitive. But here's the problem. Culture takes time. And that time lag creates a really dangerous gap between when a patient comes in and when you actually know what antibiotics will work. In an era of XDR, that's a gap you really can't afford.
When you get it on the plates, Salmonella typhi leaves some pretty classic clues. On McConkey agar, it's a non-lactose fermenter, so you're going to see those pale, colorless colonies. But the real giveaway is on media like XLD or bismuth sulfite agar. It's a strong hydrogen sulfide producer, and that gives you those unmistakable red colonies with black centers on XLD, or those discrete black colonies with a metallic sheen on bismuth sulfite. That H2S production is a huge tip-off.
Okay, moving on to the biochemicals. The profile here is also really distinct. The TSI tube is the classic test, right? You get that K/A reaction, alkaline slant, acid butt, with hydrogen sulfide. But here's the key differentiator: no gas production. That lack of gas from glucose fermentation is a fantastic little clue that helps separate it from a lot of other Salmonella serovars. It's also indole and urease negative, which helps you rule out things like E. coli or Proteus.
So, to get around that dangerous time lag we talked about, we have to turn to molecular diagnostics. PCR is the way to go. You can look for the INV gene, which is conserved across the Salmonella genus, or you can get more specific with the FLC gene for the flagellin. But really, the best target is the VIA-B operon. These are the genes for the vicapsular antigen, a major virulence factor, and they are highly specific to Salmonella typhi. A PCR targeting VIA-B can give you a rapid, accurate answer straight from a blood sample, closing that diagnostic gap.
All right, so we know how to spot it, but the real story, the one that makes this a modern superbug, is its incredible ability to acquire resistance. This isn't just a random accident. It's a textbook story of escalating selection pressure.
And this is how it happens, step by step. First, you had the emergence of multi-drug-resistant or MDR strains. These acquired a big INCH1 plasmid that carried genes for resistance to the old workhorses, ampicillin, chloramphenicol, and trimethoprim sulfamethoxazole. Then, as we started hitting it with fluoroquinolones, these MDR strains just layered on more resistance, this time through chromosomal mutations in the GIRA A and PAR-C genes.
But the final blow, the one that created the XDR superbug, was when these fluoroquinolone-resistant strains picked up a new plasmid. This one carried an ESBL gene, giving it resistance to third-generation cephalosporins like ceftriaxone. And just like that, you have a bug resistant to 5 different classes of antibiotics.
So how on earth do you treat this thing? This is our counteroffensive. But it's not simple. It's become a really complex chess game, and the right move depends entirely on where in the world you are. This table really lays out the dilemma. If you look at, say, the Dutch swab guidelines for an adult, they might list superfloxacin for an uncomplicated case. But, and this is a huge but, they immediately add a note to use azithromycin if there's a history of travel to Asia. That tells you everything. Now look at the WHO or MSF guidelines. They've shifted. Azithromycin is the first-line oral option. For severe cases, it's IV ceftriaxone, and for confirmed XDR strains, you have to escalate all the way to a carbapenem, like meropenem. For kids, the story is similar. Azithromycin is preferred, and you really try to avoid fluoroquinolones.
Of course, none of this treatment works without accurate susceptibility testing, and for that, you need the right breakpoints. Looking at the EU CAST guidelines, you can see the breakpoints for ciprofloxacin, ceftriaxone, and meropenem for systemic infections. But I want you to look closely at azithromycin. See that caveat? The breakpoint of 16 milligrams per liter is only for Salmonella typhi and paratyphi. That's a super important detail for any of you in the lab, because using it for other Salmonella would be a mistake. It's absolutely critical for correct interpretation.
Okay, let's shift gears from treating the infection to preventing it. We need to talk about fortification, how we build our defenses against this bug.
And control has to happen on multiple scales at once. In the hospital, it's pretty straightforward. Standard precautions for everyone, and add contact precautions for patients who are incontinent. In the lab, this is a biosafety level 2 organism, and you absolutely have to use a biosafety cabinet for any aerosol-generating procedures. Zooming out to the community, typhoid is a legally notifiable disease, which should trigger contact tracing and, critically, excluding food handlers until they're cleared. But the real long-term solution isn't in the hospital or the lab. It's in public infrastructure, what we call WASH. Water, sanitation, and hygiene, plus the programmatic use of typhoid conjugate vaccines. Because perfect hospital IPC means nothing if the source in the community isn't fixed.
And that really gets to the heart of it. This quote says it all. You can't solve this problem from just one silo. The doctor at the bedside, the scientist at the bench, and the epidemiologist in the field, they all have to be perfectly integrated. It's the only way to tackle a challenge like this.
Which brings us to our final section, and it's a sobering one. Where do we go from here?
So here's the question we have to ask ourselves. We've seen the step-by-step evolution. Resistance to azithromycin and even the carbapenems, well, it feels almost inevitable at this point, doesn't it? The bacteria will keep evolving. So the question isn't if we're going to see widespread resistance to our last-line agents. The real question is when it will happen and what on earth is our plan for that day. And that's our deep dive into the challenge of Salmonella enterica serovar Typhi. It's a massive issue, and we'd genuinely love to hear your take on it. What are you seeing in your labs or your clinics? Let us know in the comments below. Hey, if you found this useful, please subscribe for more explainers just like this one. Thanks for watching.